Okay, back by popular demand. EMT lecture by EMT instructor. Chapter 15, respiratory emergencies. Let's find out about some respiratory stuff. So patients often complain of dyspnea. We are going to encounter a lot of patients throughout. You're going to run in some when you're just doing your clinicals, but then you spend some time on an ambulance. Within several years, you're going to have around on several hundred patients that were complaining of dyspnea. Lots and lots of reasons why they could be complaining of dyspnea, but you're going to run on a lot of them. And what we're talking about with dyspnea is that feeling of shortness of breath or even having some difficulty breathing. So that when we say the word dyspnea, it can be important that you remember that word. That's what we're talking about is difficulty breathing or shortness of breath. Now, there's lots and lots of reasons. A common cold can be a reason. Asthma because of the tightening of the airways, heart failure because of the fluid backup, pulmonary embolism because of that blood clot that travels back to the lungs, to the circulatory system in the lungs. So dyspnea's causes can be really difficult to determine. So you kind of have to build you a good history and kind of do a really good physical assessment so you will be able to hopefully get on the right page here. Now, several different problems may contribute to a patient's dyspnea at the same time. You could have someone that is having an allergic reaction to something and they already have COPD or they already have congestive heart failure. It's just one thing on top of another. So think about that. You have one thing that's tightening the airways and then another thing that's actually putting fluid into the lungs. So you have decreased space as well. So, we can have lots and lots of issues. So now, what you need to remember and recognize is that even without a definitive diagnosis, not a differential diagnosis, differential being it could be this versus this versus this. So we're talking about a definitive diagnosis that you know exactly what it is. You still have an opportunity to really help someone. And let's go as far as to say that you could save someone's life by knowing the right things to do at the right time, especially for respiratory. Now, anatomy, nothing too fun. Nothing too fun about the anatomy system here, respiratory system, but it includes all the structures that contribute to breathing. So you got diaphragm, chest wall muscles, accessory muscles, nerve to the muscle, nose and mouth, jaw, oral cavity. Let's take a quick look here. So we're talking about the pharynx at the upper portion of our airway. We go down into the epiglottis here. We go down into the larynx, the trachea. This is all upper airway stuff. Whoops, I'm sorry, I'm pointing on my other screen. So we have the pharynx, and you see it back here, down to the epiglottis and the larynx and the trachea, all upper airway stuff. We get down into our lower airway at trachea, bronchioles, main bronchi, pulmonary capillaries. This is where all the business happens, right? But I say that all the business happens here, but without all of this, without what's the right word I'm looking for? Conduit, essentially, for air to travel in and out, we wouldn't have all the stuff going on down here. So it's important to understand all these. It's important to understand your upper and lower airway and each of the different pieces. So the principal function of the lungs is going to be respiration, which respiration, remember, we talked about it, it's the exchange of O2 and carbon dioxide, or CO2. When it happens, the air travels through the trachea into the lungs, and then it goes to the bronchi, the bronchioles, and finally arrives at the alveoli. So the bronchi being the larger airway, it goes smaller to the bronchioles. So see, we're talking about here, we've got the bronchi, now we have the bronchioles, and then we break down into our alveoli. So the alveoli is where the actual exchange takes place, and that exchange is what? Oxygen and carbon dioxide. That's what the exchange that we're talking about. So we'll move on to respiration process. So there are two processes that occur during respiration, and you see them listed here. Inspiration, nothing too fancy, okay? The act of breathing in or inhaling, and then expiration. Now, I bet if you got inspiration right, you knew that it was the act of breathing in. I bet you can get expiration right too, because that's the act of breathing out or exhaling. Now, oxygen is provided to the blood and CO2 is removed from it. In healthy lungs, this exchange of gases takes place very rapidly at the level of the alveoli, but in damaged or sick lungs, it's not going to work quite so well. You have a process that is not as efficient as it might be. Now, let's talk about this. So we see we've got the bronchioles here. Remember, we had the bronchi that would have been like over here. It comes down to the bronchiole. See, we've got the arteries, the veins, all this stuff. But we get deoxygenated blood. It's carried from the heart to the lungs by the pulmonary arteries and arterioles. So we see that blood's brought through. Now, gas exchange takes place at the capillaries covering the alveoli. So the alveoli and the capillaries. And then we have what we have oxygenated blood is carried from the lungs to the heart by the pulmonary veins and venules. So it's all going back. So it's just this constant process that happens of O2, CO2, what we need versus what we don't need, constantly exchanging. Now, in the alveoli, oxygen passes freely through the tiny passages in the alveolar wall into these capillaries, and the way it happens is through that process of diffusion. So, it's then carried to the heart, which pumps the oxygen throughout the body. Now, carbon dioxide, it also returns back to the lungs, and it diffuses. We talked about diffusion a little bit, but it diffuses back into the alveoli, and then it travels back up to the bronchial tree and exits through the upper airways during exhalation. So not a complete really complicated process, but it's a process that you need to make sure that you know. Now, moving on, we understand that the brain stem senses the level of carbon dioxide in the arterial blood. Remember, we've talked about some of those different receptors, the chemoreceptors. Now, if the level of carbon dioxide drops too low, you'll see some different things happen. One of them being the person will automatically, because this is not something that we necessarily control, our brain does it, we start breathing at a slower rate. If the carbon dioxide drops too low, we start breathing at a slower rate and less deeply. Now, what we can expect from that is less carbon dioxide is expired, and levels in the blood are going to hopefully, as everything works properly, are going to return to normal. Now, if the level of carbon dioxide rises above normal, then the person breathes more rapidly and more deeply, more carbon dioxide diffuses out of the bloodstream, and then levels in the blood are thus lowered. So it's a back and forth thing. It's one of these feedback loops that the chemoreceptors will recognize something, and then it causes the body to do something a little bit different to fix it, to go back to homeostasis, right? Once again, it keeps coming back to homeostasis. Now, the proper exchange of oxygen and carbon dioxide can be hindered by a number of things. So abnormal pathologic conditions in the anatomy or the airway. So, some abnormal conditions. Disease processes can certainly do it. Traumatic conditions can. And then pulmonary vessels, which may have abnormalities that also interfere with the blood flow. So the EMT, when we start talking about being an EMT, what does all this mean to us? Well, we need to be able to recognize that the signs and symptoms of inadequate breathing, right? We've talked a lot about adequate breathing and how important adequate breathing is. We need to be able to recognize that is not adequate or it's inadequate. We also need to know what to do about it, right? Because who cares if you can figure it out? If you can do something about it, but you don't do anything about it, you're of no value. You're worse than just a bystander, because you're actually making things worse. You're supposed to be helping, and you're not. So carbon dioxide, we see within this, there's some carbon dioxide retention in the hypoxic drive. We've mentioned that before. So what happens is patients will sometimes have an elevated level of carbon dioxide in their arterial blood. Now, you get a lot of causes for that. Some are exhalation process may be impaired by the lung disease, or the body may just naturally produce too much carbon dioxide. Now, the thing is, if these levels stay high or too high for a period of years, then the respiratory system kind of gets rewired. Okay, the respiratory center in the brain is not going to function properly. And what that could do is really start causing and signify some chronic carbon dioxide retention. So the brain gradually accommodates high level of carbon dioxide, and then it uses this kind of backup system that we call a hypoxic drive. And what that does is controls breathing based on the low levels of oxygen. So I say all that to say this: we want to be cautious when we're administering O2 to these patients. They're working off a hypoxic drive, so typically all of their numbers are a little bit different than what we expect. Their CO2 is a little higher, their O2 is a little lower, but that's normal. So what we're saying with this theory of hypoxic drive is when you start kind of washing them out and giving them too much O2 and they're losing off CO2, the body's not going to react properly. And you could potentially, with this idea, potentially just shut them down. Now, dyspnea, we decided, was going to be some difficulty breathing or even shortness of breath. Now, it can be caused by many medical problems. So, we need to be aware of these things and need to kind of think our way through this. So if the brain is deprived of oxygen, then a patient may or may not be alert enough to even complain about it. So altered mental status might be a sign that the brain is dysfunctional because of severe hypoxia. So altered mental status is one thing. Now, patients often having difficulty breathing and or hypoxia with the following medical conditions, okay? They can have difficulty breathing with pulmonary edema, hay fever, pleural effusion, we'll talk about that, obstruction of the airway, hyperventilation syndrome, environmental industrial exposure, carbon monoxide poisoning. You see that the list of things. Pulmonary effusion, we'll speak about it, but just so you can get it right now while we've mentioned it, what that is some fluid that's between the lung and the chest wall, and what happens is it starts compressing the lung. So as we can imagine, that's not a very good thing. So we do want to be aware that one or more of the following situations may exist in these dyspnea patients. So gas exchange between the alveoli and the pulmonary circulation is obstructed by fluid in the lung, can be infection or even collapsed alveoli, which that's an important word you're going to need to remember. The collapsed alveoli, another word for that is atelectasis. You're going to see that again and again, and I want you to make sure that you're aware of that. The alveoli then are damaged and cannot transport gases properly across their own walls, which is obviously going to be a big problem. And the air passages are obstructed by muscle spasm, weakness, weakened or floppy airway walls, cause a problem. Blood flow to the lungs is obstructed by blood clots, pulmonary embolism stuff that we talked about. And then the pleural space is filled with air or excess fluid, so the lungs cannot properly expand. So we've talked about all of these different conditions in one way or another. Talked about, pneumothoraxes, and we talked about pleural effusion for that last little number that we looked at. So here's some causes of dyspnea. Signs and symptoms, or not causes, but signs and symptoms of some dyspnea or inadequate breathing. So first off, they tell you they have difficulty breathing or shortness of breath. They have an altered mental status. We mentioned that. They appear anxious or restless. The respiratory rate's too fast or too slow. Their rhythm is not normal. It's in their irregular rhythm. Now, a big thing, the skin is pale, cool, clammy, cyanotic. Those are big deals. If you see adventitious breath sounds, that's going to be important for you to remember as well. You're going to see that again. And what we're talking about is those abnormal breath sounds. So it sounds like it's really kind of like a really big deal, adventitious, big word, but essentially just think abnormal breath sounds. So you can hear them wheezing, gurgling, snoring, crowing, stridor. So inspiratory, expiratory wheezing, lots of weird snoring, probably from the tongue being maybe obstructing an airway, fluid in the lungs, a lot of different things. But those are adventitious breath sounds. Then you see decreased or noisy breath sounds are heard on one or both sides. Patient can't speak more than a few words, so just a couple of words sentence. Accessory muscle use. Now, big one, unequal or inadequate chest expansion. They also may be coughing excessively. They may be sitting up in a tripod position, right? So the patient's sitting up, leaning forward, trying to put themselves in a better position to move more air. Or even they may have pursed lips. So Their lips may be pursed and kind of blowing against that. What that's doing is opening up their alveoli naturally, kind of mimicking CPAP. So some of these causes, they may also complain of chest tightness or air hunger. Dyspnea is a common complaint in patients with cardiopulmonary disease. Main reason, congestive heart failure. Congestive heart failure causes it to pump inefficiently and then ends up depriving the body of oxygen. What you get with that is some pulmonary edema. And that's a symptom that we see with congestive heart failure quite often. Now, also severe pain can cause a patient to experience rapid or shallow breathing without the presence of a primary pulmonary dysfunction. So in some patients, breathing deeply causes pain because it expands the chest wall, many times like somebody with a rib fracture, or even if they have pneumonia and stuff like that. Okay, we're going to stop this one and we'll do another one.